Hi everyone, this is Sherry Bellringer. I'm an associate editor for Prescriber's Letter and Pharmacist's Letter. This first set of recommendations is about when it's appropriate to use more than 81 milligrams per day of aspirin for the prevention of cardiovascular events. So panelists, you'll notice that we give a couple exceptions when you would want to use a dose higher than 81 milligrams of aspirin, such as for somebody that's having an acute MI for that first dose, and also within 48 hours of an ischemic stroke. So panelists, did we get all the exceptions, or are there more that we should be including?
Yeah, I think this is a first. I would definitely endorse the first dose rule. So as you mentioned above, it does take a couple of days for the full effect of low dose, and virtually all of the cardiovascular trials data did use higher doses for that initial dose. And it makes some pharmacologic sense to do so because you've got all those platelets uninhibited, and so we do a first dose higher by convention, and so I definitely endorse that.
One comment, though, is I think although the trials use the higher doses, we really don't know the answer, but I think that when you have trial data, I think we're kind of required to tell people to use the higher first dose.
Going back to our exceptions, now you guys seem to be okay with what we have as far as using higher doses during an acute MI or an acute ischemic stroke, but there's two situations that we came up with that seem to be a little bit more controversial, and one of them is CABG. If you look at the guidelines, they say 100 to 325 of aspirin after CABG, and the actual labeling for CABG is 325. So tell me what you think about CABG. Should that be an exception or not?
Oh, it's so difficult to know. It doesn't make any biological sense in the sense that we know that, in fact, I'm sure many of you are aware that some European countries, they give 75 milligrams 3 times a week.
Oh, okay.
They give even lower doses than we do.
Yeah, I did hear they gave even lower doses, so that's interesting. So Steve and Craig and Andy, what do you all think as far as a recommendation for CABG? Would you feel comfortable with 81, or do you think that we should be recommending more in those patients?
Like she said, it makes no biological sense that you need more than 81 after the first dose, and maybe not even with the first dose. So, yeah, I guess I don't have enough to feel like I can counteract whoever wrote that, who feels like they understand CABG.
I would like to. I have not. I must tell you, I have not reviewed the literature here, but I think if the only doses that have been studied are 325, it's very, very tough to make a recommendation that flies in the face of what the clinical trials showed, even though the trials never tested 81 milligrams.
Okay. And Craig, if you correct me if I'm wrong, at a dose right around 81 daily, you are completely inhibiting platelets, and anything above that just doesn't make sense that it would help you anymore. And I think that's what we're trying to get across, that 81 makes sense because of what it does pharmacologically, and beyond that doesn't make any more sense.
Yeah, after several doses, and actually even at 30, so because we set a paper out in one of the Nature journals earlier this year where we looked through for ischemic stroke, not for stroke for AFib prevention, but the data there is doses as low as 30 milligrams are effective as higher doses. So 81 may not even be necessarily the low point, but 81 is plenty once you've been on it for kind of more than 3 days.
I think you guys are making a lot of good points about why 81 is good. Now, there's one other exception that we don't have in the article, but we've been kind of questioned on a bit, and that's atrial fib. What are your thoughts on that? For those patients that can't be on an antithrombotic, because obviously in most cases atrial fib patients should be treated with or anticoagulant such as warfarin or dabigatran. So what are your thoughts on AFib? If somebody is going to be on aspirin for AFib, are you okay with 81?
I would try to talk them out of aspirin for AFib, period. I'm serious.
You took the words right out of my mouth. Yeah. It's just not very effective. And
why not a sugar pill?
Actually, guys, as much as we're joking about it, if you actually review the literature, and I got a chance to do that when, I served on the FDA panel for dabigatran and rivaroxaban, aspirin is effective. It's just so much less effective than warfarin or 10A or direct thrombin inhibitors that it's hard to advocate it. But as I recall, the studies that were done with 325, and so we're kind of screwed here in that that's all we have. But I think 81 is probably right.
Okay.
Yeah, I'd be comfortable using it, Sherry. The new chest guidelines did elevate antiplatelets a little bit, just so everybody's aware. And so if you are low, Steve and Andrew are absolutely right. It's not very effective. It's about 25% relative risk reduction compared to 80 or 90 if you use anticoagulants properly. But but the bleeding risk is less, and so it's not totally unreasonable for someone with a very low risk, but yet not very effective at all. And I'd be comfortable using 81, but Steve's right. Most of the day is with 325, so you're making a pharmacologic inference.
And Jill, why don't we go ahead and get to some audience questions?
And I've got a great one, very practical. Okay, this comes from a family physician, and they say, I still have a lot of patients, especially stent patients, that are on 325 milligrams of aspirin. They're started on this dose by their cardiologist. Should I be lowering this to 81 milligrams?
If you're on ticagrelor as your dual antiplatelet, you should be on the lower dose. And so I'll let Steve give the opinion of the cardiologist, but yeah, in my mind, it depends on if you want to be seen as changing your cardiologist orders, but 81 is perfectly fine in those patients.
Yeah. Something fascinating occurred in the Plato study of ticagrelor is in Europe, everybody was on low dose, and in America, everybody was on high dose. And again, it's this mentality that a little bit good is a lot better. And part of what we're trying to do here, it seems to me, is educate our audience that lower in this case is actually better. And, probably it's better across the board. And so when I find patients on 325 in my clinic, I drop them to 81.
You do, okay. And so that's our question. And
well, Steve, to add on to that,
go ahead.
If I saw one of your patients and dropped them from 325 to 81, do you see cardiologist you being upset by that?
Yeah, good question.
I wouldn't be upset, but I have colleagues that would probably go completely ballistic and
I think that's true, Steve.
foaming at the mouth. And the problem is that, there's always going to be some level of ignorance out there. And, my view is that we should tell people what the science tells us and recognize that it may cause some controversy, but it's the right thing to do for patients because who needs a GI bleed? I mean, people die of GI bleeding.
Thanks very much, Drs. Nissen, Williams, and Donato, for your help finalizing these recommendations about what dose of aspirin to use to prevent cardiovascular events.